بسم الله الرحمن الرحيم. Today we are about how the management for any specific disease. وبداية هو أهم system in the body that related the mouth is the gastrointestinal tract disease. Of the gastrointestinal tract, the simple anatomy of it, we have start from the mouth. The mouth has upper and lower lip, and there are cavities or cavities that have salivary glands, major salivary glands and minor salivary glands that secrete the saliva for mastication of the mouth, and then go to the pharynx, from the pharynx to the esophagus as passage that connects the pharynx to the stomach. In the stomach, we have many digestive processing, that is muscular organs that have connection to the duodenum, and small intestine. That first part is the duodenum, and then duodenum and ileum, and then the large intestine that have go to the rectum and go outside the feces. The GIT system that have the esophagus that connect to the stomach and to small intestine and large intestine. The small intestine have duodenum, and you have the then the duodenum and ileum, and connect to large intestine that have the ascending colon, the transverse colon, descending colon, and the in part rectum, and go to the anus outside. The stomach have a muscular organ that is consists of the body, and the upper part is the fundus that connects to the esophagus to cardiac openings that have cardiac notch, and go to the small intestine, to the duodenum, to pyloric infram, to the pylorus that go the food small intestine. The layer of the stomach from inside the mucous membrane that have a rodi of mucosa, and we have the muscular feature smooth muscle that is oblique, circular, and longitudinal muscular layer, and covered by a serous membrane is peritoneum. This is the structure, and we have many glands within the mucus of the stomach that secrete enzymes and HCl to digest the food. This figure shows the cross-section through the layer of the stomach, from a lumen of the stomach to the mucosa, that submucosal layer and muscular layer and serous membrane. The second part is the duodenum that have two major structures that secrete its enzyme and hormone to the small intestine. The first one is the liver. We have the beneath the liver, the called bladder, to secrete bile to digest the food, that lipid type. And we have pancreatic, and we have pancreatic juice, that one of enzyme, a hormone that secretes insulin to digest the glucose in the and can easily absorb through the capillaries in the duodenum, and in the duodenum to go with the blood secretion. The duodenum, this figure shows the section to the first duodenum, and there are circular fold of the mucosa, and we have a muscular layer, and we have the peritoneum. The beginning is pyloric sphincter that prevents the return of the food from the small intestine to the stomach during contraction of the stomach, that go outside of stomach, and then relaxation don't enter this food to the stomach. And we have capillaries within the mucosa of the duodenum that absorb the food particles to major duodenal papillae. And the most important diseases is the ulcers in the GIT, and the most common one is peptic ulcer. The peptic ulcer is the ulceration within the stomach or duodenum and may go upside to the esophageal ulcer. We have, in general aspect, in ulceration that develop in or close to acid-secreting area in stomach that have gastric ulcer, or proximal duodenum that called duodenal ulcer, and come lately in the esophageal called esophageal ulcer. The peptic ulcer appears to affect up to 30% of general population, mostly men over the age 45 years. They are typically single and persistent, not have any complete healing or remission for this ulcer. Duodenal ulcer is the most common, and many affected patients have acid hypersecretion. Patients with gastric ulcer typically have normal acid protection. The gastric ulcers commonly have HCl, so not have any hyper acidity that affects for gastric ulcer. But the HCl go outside of the stomach to the duodenum that leads to have an ulceration. Peptic ulceration is found in 70–90%, but most carriers have no disease. The asymptomatic conditioning of the peptic ulcer. This figure shows the duodenal ulcer within duodenum and the gastric ulcer within the stomach. The etiological factor is microbiological effect is by bacteria called it Helicobacter pylori. It is a spiral bacterium that have a spiral in shape that live in the stomach in normal condition, and duodenum is the most common contributory cause to peptic ulcer. This is the normal commercial that live within the stomach, but if become aggressive that lead to peptic ulcer. Helicobacter pylori survive in the mucosa lining and releases gastric acid via the enzyme urease. This converts urea, which is abundant in the stomach from saliva and gastric juice, into bicarbonate and ammonia towards strong bases. The reaction of urea hydrolysis is important for diagnosis of Helicobacter pylori. So the strong base that affect on enzyme called urease change the saliva gastric acid to bicarbonate and ammonia that is lead to ulceration stomach. This figure shows the base shape of the Helicobacter pylori and its formation. The Helicobacter pylori has that immune response cannot reach it, and the polymorphs may release their destructive superoxide radicals onto the stomach lining cell, causing gastritis and perhaps eventually a peptic ulcer. لأن عدم وجود blood or lymphatic within the mucosa of the stomach or duodenum, this is the Helicobacter pylori can growth and lead to simply gastritis or may lead to peptic ulcer. Helicobacter pylori may also stimulate gas release. This bacteria may have stimulated the gas gland to release gasoline that leads to change the saliva or gastric hormone to the bicarbonate and ammonia. Helicobacter pylori is found in the mouth, especially the gingival sulcus, and believed to be transmitted orally. It is possible that Helicobacter pylori could be transmitted from stomach to mouth through gastroesophageal reflex and then transmitted through oral contact. This microorganism through the vomiting that go from the stomach to the oral cavity and lead to ulceration like ulcer. We have other predisposing factors that lead to peptic ulcer. The first one is aspirin and other non-steroidal anti-inflammatory agents, corticosteroids, smoking, high alcohol intake, diet, stress, genetic influence. Hereditary relatives have their fault risk, and there is an association with blood group O. that don't have any reason but lead to more peptic ulcer. This figure shows the pathology of Helicobacter pylori with gastric acid and peptine and non-steroidal anti-inflammatory drugs that lead to have breaking to the mucous membrane and lead to ulceration, and this lead to go to submucosa and the muscular layer and may lead to perforation of the stomach or the duodenum. The complication of peptic ulcer with right gastrin level. This disease leads to have increased in gastrin secretion, like Zollinger-Ellison syndrome, gastrin production tumor, hyperparathyroidism lead to high serum calcium, provoke gastrin release, chronic renal failure, poor gastrin metabolism, and lead to increased gastrin level in the stomach and duodenum. The Zollinger-Ellison tumor in the pancreas, this leads to increase gastrin enzyme that go to the duodenum and lead to ulceration of the hyperacidity. We divide peptic ulcer to two categories, acute stage or chronic stage. Acute stage is rapid symptom of the peptic ulcer. The acute type, less frequent than chronic type, esophagus, stomach, proximal duodenum, develop from area of erosis, gastritis, the etiology, stress, or shock, like burns, major trauma, is the hypotension, the pathogenesis, acute hypoxia of surface epithelium. There are three outcomes. Either goes serve bleeding or heal with no patient or chronic peptic ulcer. This outcome that from the acute peptic ulcer. The chronic one is lower esophagus due to gastric reflux, stomach and duodenum, most common due to the HCl, increase in secretion of hydrochloric acid. The gross morphology, usually 1 to 7 centimeters, sharply defined inside outwash with the non-elevated margin and the smooth base. Histological feature, floor of the fibers scar with every of granulation, tissue inflammation, and nephrotic slough, depth into muscular area. The complete healing results in replacement of mucosal muscle with fibrous tissue and surface scar that have healed by scar of the mucosa to normal. The clinical feature of the peptic ulcer. The first and important clinical feature symptom is epigastric pain. The pain on the area of the stomach in the epigastric area. Some have no symptom and first sign of an ulceration of the complication. There are many complications from peptic ulcer, and it is the first sign for this disease, like hemorrhage, perforation, pyloric obstruction, stenosis with vomiting. The hemorrhage of peptic ulcer, 5% of emergency admission to the hospital due to severe hemorrhage. 80% stop spontaneously, 10% of patients die due to severe hemorrhage, cannot stop it, and rebleeding increase mortality by 10%. That have the death due to hemorrhage is. The peptic ulcer may lead to bleeding or perforation, emergency situation that have led to the beginning of the submucosal layer as have capillaries erosion, lead to severe bleeding, and then go to the mucosal and peritoneum, lead to perforation, and go the content of the stomach to the peritoneal area and may lead to death. The stenosis or perforation, proliferation of the mucosa that have increased the lumen and in the stomach that lead to have reflex that go as vomiting to the content of the stomach. How to manage this patient? The management include diagnosis and treatment plan. The diagnosis by endoscopy, barium meal radiography, gastric acid assay, the estimation of serum gastric level, the presence of Helicobacter pylori can be determined by biopsy, serology, and stool tests. The endoscopic feature by the endoscopy through the oral cavity and reach to the stomach and duodenum and can diagnose and may have taken a biopsy or may have taken the ulceration as a treatment by endoscopy. This figure shows how can take a biopsy from the ulcer, or if it is small, we can remove it all ulcer. The X-ray by the barium meal that taking barium through the oral cavity and can see all the distribution from the mouth to the duodenum, and you can see if there are any ulceration in the stomach. Or we can see this figure of the barium meal X-ray for cirrhosis of patients. The microbiological feature by the dark field, and we can see through the culture that have the Helicobacter pylori present within the mucosa secretion of the. How treat the peptic ulcer? First, non-drug treatment, particularly bed rest, dietary change, and stopping smoking, limiting alcohol intake, accelerate the healing of gastric ulcer. If not need treatment and become healed is enough, but if there are any microorganisms that Helicobacter pylori is very strong bacteria that need terrible therapy. This 3 antimicrobial to eliminate Helicobacter pylori and 14 PAP inhibitor. Such above is effective for over 90% with little risk of relapse. And we give certain drugs that 14 PAP inhibitor for the patient for healing of peptic ulcer. And if the medical treatment not penetrate the gastric surgery, that hemigastrectomy and or duodenectomy for the patient. This is hemigastrectomy and duodenectomy that for the affected part of you. An additional reason to treat Helicobacter pylori infection is that it may lead to gastric cancer or mucosa-associated lymphoid tissue, lymphoma that may change of the mucosa and may change in the lymphatic tissue, the stomach or the duodenum. How dental management for patients with peptic ulcer? Gastric surgery may result attack of hypoglycemia and vitamin B12 deficiency. After resection, deficiency of vitamin B12, folate or iron may cause ulcers, sore trunk, or angular stomatitis. This type of anemia resulted in gastrectomy and poor absorption of the vitamin B12 or folate or iron that lead to anemia. Drugs that cause gastric irritation or promote bleeding and should not be given to patients with peptic ulcers and include aspirin and other non-steroidal chemotherapy drugs and corticosteroid therapy. Persistent regurgitation of gastric acid as a result of hallucinosis can cause severe dental erosion, typically of palatal aspect of upper anterior teeth and premolar. That is severe vomiting and continuous through the oral cavity that leads to an erosion by its gastric acid, severe acidity of the vomiting that leads to erosion of palatal surface of upper. The oral adverse effect results from medication that taking for patients that have any peptic ulcer, like benzodiazepine or sulfasalate that lead to dry mouth. The ranitidine is lead to actinomultiforme. The omeprazole that lead less uptake or actinomultiforme. The Helicobacter pylori may be transmitted in saliva. Antacid impair absorption of ciprofloxacin, erythromycin, metronidazole, and tetracycline. So if patient take antacid, not give him this antibiotic. Cimetidine and omeprazole may delay clearance of lidocaine and benzodiazepine, but affect rarely clinical significant, not have any clinical effect by the lidocaine, so can give it safely. Anemia may also complicate treatment, particularly renal anesthesia. If patient is anemic, نتيجة error vitamin C or vitamin B12 deficiency, you must treat anemia and then do any general option. Now, the disease is Crohn's disease, the regional enteritis or ileitis. What's Crohn's disease? About 2% of people with Crohn's disease have blood relatives, most often brother or sister, and sometimes a parent or child. So it is a genital transmission. The Crohn's disease appears to be a heterogeneous group of disorders probably caused by combinational bacteria in person with genetically determined dysregulation of mucosal T lymphocytes. The inflammatory response is properly mediated by factors such as tumor necrosis factor alpha. It is an inflammatory reaction by tumor necrosis factor alpha that lead to have ulceration of the GIT. Susceptibility appears to be related to locus or chromosome 60, so it is congenital. The microorganisms involved are unknown and many have been implicated. The microorganisms not have a real pathological factor, but we can see Mycobacterium paratuberculosis is one of the latest bacteria to be implemented, but it is probably not of a major importance. The microscopically Crohn's disease causes semi-polygonal chronic inflammation with many mononuclear interleukin-1 producing cells, non-caveating myeloma from the submucosa and lymph nodes that are non-specific ulceration occur in Crohn's. It affects mainly in the edge of small bowel, in the ileum part, in the beginning of large bowel, in the ascending colon. It is the most common, but it occurs from mouth to the esophagus, to the stomach, to the rectum, to the anus, at all areas affected by disease. The etiological factors is causative agents like bacteria, virus, and diet, and modifying factors like environmental and genetic factors that lead to luminal factors like luminal bacteria, digestive enzyme, bile acids lead to immune reaction, and immune response lead to inflammation and lead to tissue injury that have can see in this figure. Clinical feature of Crohn's disease affects especially the idiopathic region, typically with ulceration, fissuring, and fibrosis of the wall, but can affect any part of gastrointestinal tract. The feature of the Crohn's disease either is as an ulcer or as a fissure or fibrosis of the wall of idiopathic region. Small intestine involvement in Crohn's disease may cause abdominal pain that often means appendicitis with malabsorption or abnormal bowel habits. حقيقة المنطقة of the Crohn's disease نفسها هي اللي تكون فيها abdominal pain and is like appendicitis, so must differentiated from Crohn's disease and appendicitis. Ulcerating diarrhea and constipation are typical that either it occurs as diarrhea or is constipated region. That have chronic Crohn's disease may mimic ulcerative colitis and frequently cause chronic perineal disease. What is the most important in the area of idiopathic region in the small bowel or large bowel. The hereditary pain is a very common symptom for patients. There are ulceration, the idiopathic. There are fissuring for idiopathic, and we have many stages for Crohn's disease. The first stage is mild to moderate Crohn's disease. Is a characteristic feature. People with mild to moderate Crohn's disease are able to eat food normally without dehydration, fever, stomach pain, and blockage in their intestine or lost more than 10% of their body weight. The second stage, moderate to severe Crohn's disease. People considered have moderate to severe Crohn's disease if they do not respond to treatment for mild to moderate Crohn's disease, or if they have high fever, significant weight loss, stomach pain or tenderness, occasional nausea or vomiting, or significant anemia. The last stage is severe Crohn's disease. People with severe Crohn's disease have symptomatic distress taking steroids or have high fever, persist vomiting, blockage in their intestine, or an. The complication of Crohn's disease lead to weight loss, gastrointestinal obstruction, internal or external fistula, renal fissure abscess, arthralgia, sometimes clearing cholangitis, renal damage, renal stones or infections, a slight greater predisposition to small bowel carcinoma. This is the fissuring fistula in the wall of the abdomen. The cobblestone appearance of mucosal surface due to linear ulceration, and this ulceration narrowed of the lumen of the ileocecal region and leads to perforation and abscesses in the peritoneal. This figure shows the perforation and proliferation of cobblestone appearance in the ileocecal region. This is fissuring through the anus. How we manage the patient with Crohn's disease. The major differential diagnoses include there are ulcerative colitis, tuberculosis, ischemic colitis, infections such as gastric lymphoma is one of the most important for differential diagnosis. The appendicitis, the ileocecal region, the appendix region is very important to differentiate from Crohn's disease by diagnosis of appendix and see if it's or Crohn's disease. How we diagnose this by ESR and level of active phase proteins such as active protein and serum mucoid are usually rise in Crohn's disease. Serum potassium, zinc, and albumin are usually decreased due to reduced absorption of this potassium, zinc, albumin to the ileocecal region. Deficiency of iron, folate, or vitamin 12 as anemia can occur. Different subpopulations have serum perinuclear anti-neutrophil cytoplasmic antibodies or anti-lymphocytic and autoantibodies due to inflammatory. Barium enema of large and small bowel, or barium meal for the ileum, or barium enema for the cecal region. Colonoscopy and mucosal biopsies often show typical granulomas. The colonoscopy colon that go to the ileocecal region, and you can examine or take biopsy or treat this condition. As a subleukocyte intestinal scan may help to diagnose active disease condition. This is barium enema, and you can diagnose the Crohn's disease. This is the endoscopy for gastroduodenal endoscopy for the diagnosis of ileal region. This colonoscopy from the colon to go to the ileocecal region and diagnosis condition. The treatment plan: the first medication, sulfasalazine or newer 5-aminosalicylate, pyracillin, mesalazine or osalazine, and local steroid therapy. Any of these may be supplemented with metronidazole as antimicrobial agent. Aminosalicylate may cause headache and blood decreases, and regular blood counts are indicated for the giving aminosalicylate in each period. High fiber diet is indicated in anemia needs treatment. If there are constipations, target high fiber diet, and you must treat any type of anemia. Azothprine and 6-mercaptopurine may be used in an responsive patient and treated by the simple treatment medication. The monoclonal antibodies directed against tumor necrosis factor alpha, inflammatory may be beneficial but may have severe serious adverse. Surgery, last stage of its idiopathic region, by surgery, viruses should become necessary at some stage and most patients with intestinal Crohn's disease. However, nearly 50% relapse within a year of operation. Of all treatment is unsatisfactory for Crohn's. This figure shows a triangle based on Crohn's disease given antibiotic, aminosalicylate, and nutrition support. In moderate, prednisolone, 6 anti-AZX, and baseline sided Crohn's, and severe case surgery, nationalized anti-inflammatory factors. How we manage our patients with Crohn's disease. Dental management very complicated by other problems, which is malabsorption or by corticosteroid therapy, immune suppressive drugs, and steroidal anti-inflammatory drugs should be not given to the patient with the Crohn's disease. Antibiotics that could aggravate the area should be avoided. This includes augmentin, clindamycin. Oral lesions of Crohn's disease include ulcer, fissure, or labial swelling, mucosal attack, Colitis stone, perforation of mucosa. Oral lesion may be caused by Crohn's disease itself or by associated nutritional defects, oral effects of malabsorption such as angular stomatitis, and in case of anemia and reduced immunity. This figure shows the oral manifestation of the Crohn's disease. We have syndrome called Merkelson-Rosenfeld syndrome. This kind of Merkelson-Rosenfeld syndrome is facial swelling, facial palsy, and facial tongue. Enteritis granulomatosa may possibly also accompany the manifestation of Crohn's disease. This is Merkelson-Rosenfeld syndrome sign. Patients with atypical ulcers, especially when they are large, linear, and rugged, or those with recurrent facial swelling, should be a biopsy of mucosa. The finding of non-calcating granulomatous cobblestone or patient of oral mucosal Crohn's suspected of Crohn's disease. High prevalence of caries and peritonitis. Crohn's disease has also been reported due to vomiting, and don't have any importance for hygiene. The last disease is ulcerative colitis. What ulcerative colitis is an inflammatory bowel disease affecting part or all of the large intestine, frequently of lower colon and rectum, that affect ulcerative colitis in large intestine. The ulcerative colitis causes inflammation and ulcer in superficial layer of large intestine mucosa plus basido polyp formation that have proliferation of the mucosa of large intestine. The lining layer of the normal person, normal rogi, but in the inflamed area it becomes red or ulcerated layer. The normal lining of colons and have colon with ulceration, make more than 1 to 2 ulceration in the lining of the bowel. The ulceration of large bowel and transverse colon and descending colon and leads to the rectum. The staging of the ulcerative colitis from stage 1, stage 0 is small ulceration, stage 1 large, and stage 2, 3, and stage 4 lead to perforation of large intestine. The pseudo polyp that occurs in the lumen of a small intestine. Ulcerative colitis most often affects people between the age of 15 to 40 years. The etiology is unknown. Somatic symptoms are often associated. The psychology of the patient is very important in ulcerative colitis. فلهذا يسمى التهيج القولون العصبي. Clinical feature. The typical feature of ulcerative colitis is the yellow food containing intermixed mucous blood or pus that have within the feces of the ulcerative colitis. In severe cases, there is abdominal pain, fever, nausea, and weight loss, and area of the intestine. we have extra-abdominal signs. The extra-abdominal signs of ulcerative colitis may be minimal unless there are complications like iron deficiency anemia caused by blood loss, arthralgia, arthritis, uveitis, finger clumping, erythema nodosum, and other skin lesions such as paradermal gangrenosum, and also be fibrosis. Overproduction of platelets, some clot factor may lead to thromboembolism. Various types of liver disease may complicate the disease. The disease extension through the mucosal layer may result in toxic megacolon, colon dilate, and can perforate lead to carcinoma. The complication of ulcerative colitis, most serious complication of colitis is carcinoma of colon. This is up to 30 times more frequent than the general population and most likely to develop in patients with early onset colitis or with disease persisting for more than 10 years. How we manage the ulcerative colitis start with the diagnosis of the cases that there is barium enema of large bowel. No ulcerative colitis for large bowel. The most effective for diagnosis is X-ray by barium enema. And we have sigmoidoscopy and colonoscopy. The sigmoidoscopy and rectal biopsy established in the diagnosis. The colonoscopy is necessary if any polyp are seen radiographically, if the not reach to ascending colon and first colon, not enough for the sigmoidoscopy, we use colonoscopy. Barium enema for all large intestine can see to the sigmoidoscopy for only the rectum, the sigmoid area, and we can diagnose it and take a biopsy, and if it's a small lesion, we have to treat it by colonoscopy, sigmoidoscopy. The colonoscopy, if the lesion is reached to the ascending colon and go to the small intestine ileal lesion. We have difference between colonoscopy and sigmoidoscopy. The difference between these two features of diagnosis, the colonoscopy is peritoneum colon, right-sided colon, no additional survival from examination with colonoscopy. We have the 6 feet tube length, the colonoscopy, but the sigmoidoscopy into the distal colon, left-sided colon, and full survival from examining with sigmoidoscope to have the length is 2 foot tube. How we treat the ulcerative colitis, we start with the medication. We use immunosalicylate and local corticosteroids, often by anemia. Anemia, a high fiber diet is indicated, and anemia needs to treatment. The systemic steroid or azathioprine may be required in acute exacerbation case. The colectomy may be indicated if symptoms are severe and the response to medical treatment is poor, or complications such as pyoderma gangrenosum or hemorrhagic develop, or to eliminate the risk of malignant change. Unlike Crohn's disease, surgery can be survived. That our patient is curative in case of colectomy. Most common measure is botulectomy with ileostomy. This is large extension before the operation, and small after operation remove majority of the large intestine. We divide the treatment through mild case, severe diagnosis. Mild is probiotic antibiotic, and then in moderate is prednisone, paclitaxel, and go to azathioprine and 6 mg, and go to surgery through biological therapy. How we manage patient with ulcerative colitis, the drugs should be avoided, include non-steroidal anti-inflammatory drugs, antibiotics including augmentin, clindamycin could alleviate the area, local anesthesia is factory, and there are no objection to conscious sedation if needed. Management complications may include anemia and those associated with corticosteroid therapy. Oral manifestations in ulcerative colitis are rare but include biostomatitis gangrenosum, chronic ulceration, biostomatitis vaginalis, and multiple intraepithelial microabscesses, and discard hemorrhagic ulcer or lesion related to anemia. Since uveitis, skin lesion, and mouth ulcer can be found in ulcerative colitis, it's important to differentiate it from patchy disease. This is the oral manifestation of actin multiforme in upper and lower. The symptom and their differentiation is Crohn's disease and ulcerative colitis. The joint swelling or pain arthritis is common in the Crohn's disease and common in ulcerative colitis. Skin rash in both is common. Mouth sore is common in Crohn's disease but not present in ulcerative colitis. Inflammation of the eye is common in Crohn's disease but less common in ulcerative colitis. Clotting problem common in both Crohn's disease and ulcerative colitis. Kidney stones is common in Crohn's disease but not present in ulcerative colitis. Abnormal liver function test is common both Crohn's disease and ulcerative colitis. Inflammation of pancreas is common in Crohn's disease but uncommon except with ulcerative colitis. Bone disease is common in Crohn's disease but less common in ulcerative colitis. Anemia is common in both ulcerative colitis and Crohn's disease. Thank you for your listening, and any question have I can answer it after the